it is necessary that apart from trying to eliminate the causative agent, which is P-falciparum, you would also have to manage the problems that normally comes with the condition. So we made a whole list of the problems: hyperpyrexia, severe anemia, renal problems, CNS problems, seizures, convulsions, hypoglycemia. Normally, all these things, some of them may be there, and therefore we should be able to attack some of these problems accordingly. So let's begin with the high body temperature that comes with it. So hyperpyrexia, you are going to use antipyretic agent to manage. Do not forget that apart from drug therapy for hyperpyrexia, you have non-pharmacological inputs such as tepid sponging in pedic. So in children, you can do tepid sponging. You can also add fanning. You fan the child to try and then reduce the body temperature. So these are two main non-pharmacological inputs that can be applied when it comes to hyperpyrexia: tepid sponging, and you fan the child. But when it comes to hyperpyrexia in pedics, preferred first-line agent is paracetamol. So paracetamol is taken normally at a dose of 15 milligrams per kilogram body weight every 4 hours. Remember, you can't go above 4 grams per day. Recently, there have been issues with IV paracetamol. I'm not talking about the other formulations, suppository orals. No. But IV paracetamol, the FDA issued this communique that once your weight is below 33 kg, regardless of your weight, we are not supposed to give you IV paracetamol. Below 33 kg, no paracetamol. If you're above 33 kg, then there are recommendations. Even with that, it is based on other comorbidity. If you're having liver issues, then you can take the normal full maximum dose of 4 grams per day. If you don't have any such issues and you're above 33 kg, then you can go up to the 4 grams per day. So note that in Ghana, IV paracetamol cannot be used for individuals below 33 kg. It doesn't matter your age. It could be 100 years, it could be 10 years, it could be 50 years. Once your weight is less than 33 kg, it's not recommended. They said it was leading to issues that could lead to mortalities, and therefore it's not recommended. Apart from that, the oral route, the rectal route could be employed. That one is safe. So 15 milligrams per kilogram body weight can't be used, and as we all know, para is well tolerated, and it can help us try to abort the high body temperature that normally comes with severe malaria. People can also tip into coma. Of course, in coma, one of the key things is to make sure that you secure the airways. Make sure that the airway is patent so that you can get in and out flows of air. Other than that, hypoxemia that may lead to hypoxia may cause a lot of problems. If it becomes necessary that you will have to do mechanical ventilation to achieve adequate oxygen supply, then intubation will have to be considered. So you have to intubate. Then you connect the patient to a mechanical ventilator for adequate supply of oxygen and respiratory control. Of course, a patient in coma is not conscious, and therefore to prevent issues like aspiration that can go into the lungs, that is aspiration pneumonia, you put the patient on his or her side so that even if anything is dropping from the GIT, it will not enter through the airways and cause aspiration pneumonia. Remember that it may not be only malaria that can cause coma. There could be other associated conditions that can also lead to coma. So those things may also or must also be considered. For example, high plasma glucose and bacterial meningitis. If some of these things are also there, they can contribute to coma. Or it could even be no malaria, but these things that are contributing to malaria. And therefore, these things must also be suspected. And if they are there after their test, you manage accordingly. More CNS issues like convulsions, that is the clinical manifestations of seizures, can also happen, especially in cerebral malaria, where either reset formation or the sequestrations within the blood vessels block the blood flow towards your brain, then reduce oxygen, reduce glucose. You may suffer from seizures and therefore will be manifested as convulsions. And as such, the patient, if it happens, must also be managed. Here again, a patient going through convulsions will not be conscious. And therefore, you have to make sure that you secure the airways as well. Pharmacological interventions, of course, you need to calm down the highly firing neurons within the brain. And therefore, agents like the benzodiazepine, diazepam, could be employed as first line to try and then abort the convulsions. It could be given per IV at a dose of 0.15 milligram per kilogram body weight. So in case it doesn't go, it could be repeated at same dose. Remember, diazepam could also be given rectally. I mean, the same IV preparation could also be given per IV. The key thing that you need to remember is that, yes, it's kind of emergency, you are rushing. But after using the needle plus the syringe to collect the drug into the syringe, if your target is to go per rectal, please do not forget to remove the needle, because you are going to insert only the syringe in the person's rectum when the drug will be injected. So please, if it is per rectal, always remember to remove the needle after collecting the drug into the syringe. Rectally transmuscular route. They said 20 milligram per body weight. In adults, the dose is 200 milligram, and this may be repeated if necessary after 6 hours. Then we hope that with this intervention, the convulsion will be out. If it doesn't go, then of course, there could be additional problems underlying the whole convulsion that is still persistent. And therefore, this must be diagnosed and attacked accordingly. We also mentioned hypoglycemia. The policy recommends that currently in malaria, they say you are hypoglycemic, then you are below a plasma glucose of 3.0 millimole per liter. Possible causes may include loss of appetite, and therefore you are not eating, you are sick. You are always vomiting anything that you even eat. It could also be due to the parasites depending on your plasma glucose. Remember, there is hyperparasitemia in the regions above 500,000 per microliter for immune guys and normally above 100,000 for non-immune guys. So they will be chewing all your glucose. And if you are also on drugs like quinine, which is a secretagogue, that could also be a contributing factor. And therefore, hypoglycemia can easily happen in severe malaria. Diagnose when the plasma glucose falls below 3.0 millimole per liter. If it's an adult, then it's okay to give 50% dextrose, 50 mils. Can infuse over 30 minutes to 1 hour. For pediatrics, you can step down to a lower concentrate, 25% dextrose at 1 mil per their kilogram body weight. After this bolus infusion, you may follow it up with a far lower concentrate, 10% glucose at a rate of 125 mils per hour, 10% dextrose at a rate of 125 mils per hour. This can also be given. In some situations, you may have cardiovascular collapse due to excessive toxemia, and this will make it very difficult to be able to even locate a vein to inject your glucose through. Should in case that happens, then alternatives like glucose powder or sugar water can also be given to such individuals via nasogastric tube. But should in case you have access to an IV line, then intravenous dextrose will be first line. Interventions like trying to feed babies in particular, breast milk, giving, if the person can tolerate orals, then you can encourage the administration of breast milk from the mom. Even eating certain foods that contain high sugar content, cocoa and other stuff. Should in case you want to prepare sugar water and give it via nasogastric tube, the formula is that you give a 4-level teaspoonful, or if it is the cube type of sugar that you have, you pick 2 and you dissolve it in 200 mils of water. Then you give it gradually through a nasogastric tube. Any queries? Any queries? Last Captain, are you there?
Yes, please.
All right. Any issues so far?
No, please.
All right. Dehydration. So dehydration here again, you are not tolerating anything per oral. You are vomiting, high body temperature. You are losing a lot of fluids, and therefore the person may be dehydrated. Remember the signs of dehydration: sunken eyes, dry mouth, loss of skin texture. Because of reduced plasma volume, there could be sympathetic activations, so there could be increased heart rate and the likes. Even poor or low urine output can occur as a result of dehydration, causing hypoperfusion of the kidneys. This can lead to even acute renal failure, and therefore severe dehydration associated with severe malaria must be corrected. Of course, isotonic solutions like normal saline will be given. 5% dextrose, if appropriate, could also be given to solve the issue of severe dehydration. At times, pulmonary edema could also occur. Remember, if you get blockade of the pulmonary blood vessels, then you could get stasis of fluid within the pulmonaries. If this occurs, it will affect oxygen delivery. That can lead to so many problems. And therefore, it is necessary that if you have low oxygen concentrations, SpO2 is going down, the person is breathless, chest tightness, then of course, you have to help relieve this issue of pulmonary edema. The recommended agent is a diuretic, furosemide. Remember, when you did heart failure, you were told that furosemide doesn't only cause diuresis to relieve pulmonary edema or issues with respiration. It also causes vasodilatation. even before the diuretic effect occurs. This occurs through the activation of nitric oxide synthase, and therefore furosemide can help you produce and release a lot of nitric oxide, which is your natural vasodilator. So with this vasodilatation within the lungs, it helps to reduce the pressure there before even the diuretic effect that reduces plasma volume occurs, and therefore furosemide is employed. It could be used at a dose of 1 to 2 milligram per kilogram body weight. Remember, it is per slow IV administration, 4 mL per minute, to avoid ototoxicity. Maximum dose will be 40 milligram per day. This is used to try and then solve the occurrence of pulmonary edema. Should in case the pulmonary edema goes with low SpO2, that is hypoxemia, and maybe you cannot treat it with furosemide, then of course you need to come in, intubate, and use an artificial machine to control SpO2. Severe malaria, we said, in adults when it falls below 7, in children when it falls below 5. And therefore, at this point, that is not where you are going to look for iron to try and then solve the problem. Remember, iron will take about a week or two to give you +1. That is when you have even fall within the therapeutic dose range. In adults, 100 to 200 milligram elemental iron per day. In pediatrics, 3 to 6 milligram per kilogram body weight per day. Even that will take you about a week or two to get +1. Look at where the values are, below 5 and below 7. We don't have that luxury of time. Again, remember, once you push in iron, the parasite could also utilize the iron, proliferate, and harm you. And therefore, at this point, the key thing that you need to do to solve the problem is you do grouping and cross-matching, and afterwards, you hemotransfuse. So hemotransfusion is the key thing that you need to do. Available products could be whole blood or packed cells. Remember, whole blood is diluted because it contains a lot of plasma compared to packed cells that you have removed some amount of the plasma. And therefore, the one that is more concentrated, whole blood, packed cells, you can give it at 10 mL per kilogram body weight, whilst the whole blood that is more diluted, you give higher volume so that you can get the equivalent amount of hemoglobin that you are looking for. Should in case you are dealing with a patient who is congested, for example, there is pulmonary edema and you also need to hemotransfuse, then of course you need to clear some of the fluids, especially when you are using whole blood, so that you don't worsen issues like pulmonary edema. And therefore, furosemide can be given first before you do your hemotransfusion to avoid worsening congestion. As I said, you could suffer from acute renal failure, even from severe dehydration. That is one of the pre-renal causes of AKI. This can occur in severe malaria, where you have your urine output going very low, less than your 0.5 mL per minute for about 1 per hour for over 6 hours. And therefore, we say that you have AKI. If this happens, you have to check the fluid status of the person. Is the person dehydrated? Because that could be the main cause of the AKI. If so, you may see some of the signs and symptoms of severe dehydration: dry mucous membranes, dry eyes, sunken eyes, loss of skin tegel, increased respiratory rates, increased heart rate. Some of these things may be there. And also you check your fluid balance. input and output. Are you having issues with oliguria? Then you have to check. Of course, normal output should fall at least between 25 to 30 mils per hour. If you are getting anything lower than this, then you are in trouble. Make sure that you do adequate hydration to solve the problem. Should the need be, then dialysis will have to come in to solve the problem, to clear some of the nitrogenous waste to avoid more problems. Obviously, peritoneal dialysis will be for long-term use. Hemodialysis, of course, will now be the appropriate. AKI may resolve, and therefore the best option is to do hemodialysis using the machine to do it. Can someone tell me the difference between peritoneal and hemodialysis? Any difference between the two? You've been presenting on kidney, CKD, AKI. So by all means, you've touched on dialysis before. What is the main difference between the two in terms of the way we do the two? Last captain.
Stanley, could you kindly help us?
Hello. Peritoneal dialysis versus hemodialysis. Briefly, the difference between the two, how we apply those two. As captain, can you mention another person?
Elsie, could you kindly help us?
Is it a network issue or they are not around? So, class captain, can you say something about this? Peritoneal versus hemo.
Please, I have no idea.
Oh, okay. Anybody? Where is Nana joining this group or the other group? Sir, Nana, sir. So for the hemodialysis, you got it right, but the peritoneal one, it doesn't involve any machine. What they do is to load your peritoneal cavity with the dialysate. The dialysate is the fluid that they mix that contains a lot of electrolytes to set an osmotic gradient. They use same fluid in the machine so that there will be difference in terms of gradient between your blood and the machine. In the peritoneal cavity, they put same fluid in your peritoneum. So they will create a hole and then load your peritoneum with the dialysate that contains some electrolyte to set an osmotic gradient. So what is going to happen there is you now have different concentrations within the blood vessels lining the organs within the peritoneum, and then the fluid that you've used to fill the peritoneum. So you are going to have an exchange of solutes. So through osmosis, so solutes, water. So there will be movement of these high nitrogenous waste substances now from the blood into the peritoneum where you have this fluid. And then at the appropriate time, maybe every day, you pour the fluid from the peritoneum, then you do a refill. So you have a lot of people moving around with their peritoneum filled with this dialysate, that is the concentrated solution that will establish the gradient to cause the movement of these waste substances from the blood vessels lining the organs within the GIT into the fluid in the peritoneal cavity. The disadvantage is that it's kind of come with a high risk when it comes to infections, because you've created this hole that you are always putting things in and moving out. So it could be infected, and of course, that could be a problem. The advantage is that, unlike the hemodialysis, you don't have to always go to the hospital and spend about 4 to 8 hours per session. For hemodialysis, almost every 3 days or so, you have to go to the hospital, or at least twice a week. Then you stay there for about 4 to 8 hours, then for the machine to do the sieving for you. With this, you take it home, you make your own rounds, and at the end of the day, you empty it and you do refill. But it's uncomfortable as you carry it around. It has a high rate of possibilities when it comes to infections. Hemodialysis is more effective than peritoneal dialysis. Just that with that one, you are going to waste your time at the hospital, and there is high possibility of blood loss, because the machine, as you said, your blood will have to leave your body, go and pass through the machine for the machine to do the filtration. Obviously, you are not going to get 100% returns. Again, there is high risk of coagulation. For the moment your blood leaves your blood vessels, it can easily coagulate, and therefore anticoagulant will have to be added in the whole treatment. So these are the two. In severe malaria, you can get AKI, and hemodialysis will be the best option. People could also get circulatory collapse, and this is normally common when the malaria comes with the secondary bacterial infections, especially the stubborn gram-negative ones that can cause a very severe inflammation. When this happens, because of the release of inflammatory mediators, for example, vasodilators like histamine, it can lead to cardiovascular collapse. That is when your cardiovascular system, because it is collapsed, you can't get adequate supply of blood to the extremities, your diggits, your fingers and toes. So when they touch your fingers and toes, those areas will feel very cold, which means you are going. Gradually, you are going. You want to move to Unananum, then visit them. And this, when it normally happens, then you must suspect, though not confirm, but you must suspect gram-negative infections. Before you even confirm, you may have to start an empirical antibiotics that will have a broad spectrum of activity so that you don't cause this problem. So after you have initiated your broad spectrum antibiotic, as always, you take your samples for culture and sensitivity. And when the results comes, if it is in line with what you are doing, you continue for the appropriate duration. If not, then you have to switch up to the appropriate recommendations from your culture and sensitivity. Any question? Any question? So these are some of the common supportive care that in severe malaria you may need to save the patient, because these are common with falciparum-induced complicated malaria. Any queries? Any queries? Class captain, any queries?
No, please.
All right. So now let's look at one of the new inputs, one of the new recommendations, reducing transmissibility of P. falciparum malaria when it comes to low transmission areas. So what do we mean by a low transmission area? So the definition is such that if you have about 1,000 cases of malaria, then 100 to 250 of the cases is caused by P. falciparum. Or in general, if 1 to 10% of the malaria cases is caused by P. falciparum, then it is described as low transmission. So areas that this occurs, we refer to those areas low transmission. The problem is that our normal ACTs that we use are unable to clear the gametocytes. And therefore, the parasites will go back to the mosquito, who is the vector. Then we get another infection. The strategy, therefore, is to make sure we clear the gametocytes in low transmission areas. And of course, again, we fall on primaquine. So primaquine doesn't only kill those in the liver. It can also kill the gametocytes that potentially the mosquito could come, and when it takes your blood meal, it ingests this gametocyte, they go back into the mosquito's gut, develop and become sporozoites, only for these mosquitoes to re-inject them into the human host. Primaquine is an agent that can kill the gametocyte in the blood. Lucky for us, a very low dose of 0.25 milligram base per kilogram body weight. Maximum dose of 15 milligram can do the job. At this dose, it is too low to cause any problem, even in those with GSPD, either partial or full defect. And therefore, it is not necessary for you to establish the GSPD status in this case before you give such a low dose primaquine. So everybody is now allowed to take this low dose as a strategy to clear the gametocyte to prevent reinfection. Preferably, the drug is supposed to be taken on a daily observed therapy basis so that we make sure that you take. So very soon, this strategy will also be enrolled. So it is part of the new recommendations that those dealing with the malaria control program, they hope that they will roll it in. Another strategy, this one we've been talking about it, is a deliberate attempt to deploy multiple first-line therapy. We don't want to cause any resistance. So we therefore want to confuse the parasite. If you keep on giving a single agent, like always artemether-lumefantrine, all the time artemether-lumefantrine, it may get to a time where nobody wants to go into extinction, and therefore the parasite will devise some means to defend itself against artemether-lumefantrine. So therefore, the strategy nowadays is to do multiple first-line therapies. For example, artemether-lumefantrine today, the next time artesunate amodiaquine, the next time again you do pyrrolinaridine with artesunate. So you keep on changing it all the time. The new drug is also new to the parasite, and therefore it is very difficult for the parasite to develop resistance. So note the deliberate deployment of multiple first line as another strategy that they hope that people will do to avoid any resistance. So key moves will be, for example, geographic approach, where you deploy different mixes in different areas of the country. So from, let's say, the central medical stores, they target this month, Ashanti region. We are pushing only artemether-lumefantrine there. At the same time, in Bono region, we are pushing artesunate amodiaquine. Next month, they do the exchange so that Bono people will do AL, whilst Ashanti will be doing. So whoever is in Ashanti region for month one will be taking artesunate, artemether-lumefantrine. But the next month, the person will go and get artesunate amodiaquine. So even on supply chain issues, they start all the way from there. You just can't get it. So you'll be forced to use what is there. And therefore, we keep on changing it from time to time. You can also do according to age categories, where you say, oh, this time I'm giving this to this age group. Next time you change it. These are all strategies to make sure that we don't expose the parasite to the same agent all the time to cause possible resistance. Any questions? Any questions? Class captain, anything that you need clarification?
No, please.
Okay. So now, to the public health guide, prevention is better than cure. You clinical guys, you also agree. You wait for the thing to occur, you spend a lot of cash. You may even not be successful and the patient may die. And therefore, we have to obey the recommendations from the public health guys so that we don't even get the condition at all. So these are some of the possible recommendations that the public health guys in malaria, they've given us as means of protecting ourselves from even getting the condition at all. So let's try and then look at some of them. So the first and obviously the most important strategy is to prevent the vector from biting you. Because if the vector doesn't bite, you don't get the parasite in your body. Key strategies, as always, you have to sleep in a mosquito-treated net. If you decide to stay outside between dawn and dusk, between that time, that is when you get possible bite. So stay indoors during this period. You can also use mosquito repellents, the sprays, the creams. Now we have creams that you can apply on your body at night. So you do all these things to prevent bite. You can also screen your windows. So the windows, you apply some nets so that the vector cannot pass through and then come and bite you. Then there are breeding places where they stay and then give birth to more mosquitoes. So you desilt stagnant waters, those that are blocked, you clear them so that they don't stay, and then for the mosquitoes to use them to breed more. So these are possible strategies that we can use, non-pharmacological, attacking it from the vector's point of view. You prevent the vector from biting you. Simple. You don't get the introduction of the parasite into your body. But in some individuals, you'll be doing this prevention of bites. But in Ghana, even when you are in trotro, you can get the bite. In the hospital, you are going to visit somebody, you can get them. So you are doing most of these things in your homes. But once you move out, even in daytime, trotro, you still see mosquitoes moving around and they can bite you from there. So in individuals who are classified as being vulnerable when it comes to severe malaria, apart from doing the prevention of bite strategies, we also give them certain medications to prevent the establishment of the malaria, even if they get some of these bites. So we have in pregnant women, the so-called intermittent preventive therapy with sulfadoxine and parametamine. Remember, sulfadoxine and parametamine are both antimetabolites, antifolate agents. So they antagonize folic acid. In pregnant women, first trimester where organogenesis is going on, you need folic acid to ensure proper protein synthesis. Anything that blocks folic acid may cause congenital abnormalities. And therefore, when you are giving an agent like a combination of sulfadoxine and parametamine, it is prudent that you give it at a time when organogenesis is over, and therefore you don't have any risk of causing any harm to the developing fetus. So this is not initiated until 16 weeks. That is 4 months. Normally, organogenesis will end by month 3. That is first trimester. But to make sure that even when there is an extension, we are also extending the time. So by week 16, that one we are sure that by all means, organogenesis is over. And even if we interfere with folic acid, this will not cause any harm because the combination that we are going to use, sulfadoxine, parametamin, both affect folic acid synthesis and folic acid effect. And therefore, the so-called quickening, 16 weeks, is when SP is initiated. Sulfadoxine, normally the SP comes as 3 tablets, each tablet containing 500 milligrams sulfadoxine and 25 milligram parametamin. You take all 3 tablets at once, and it is done from the 16th week every month, preferably every month. Also done on DOT basis, daily observed therapy. You do that in front of a health worker. Pregnant women, of course, they will go for antenatal care, and therefore that SP is added as part of a whole comprehensive package given to pregnant women. So they take all the 3 tablets, which amounts to 1,500 sulfadoxine and 75 milligram parametamin. And this is expected to prevent the establishment of malaria in this vulnerable group, pregnant women. Apart from this, the other interventions that is done in antenatal care may include the administration of iron. Of course, there is physiological iron demand in pregnancy. Yourself and the fetus. If you are not lucky, you could even have multiple fetus in your womb, and therefore the demand will be high. So that one too is given. Nowadays, worm eradication is also very important in pregnancy. These are not problems. These are not problems when it comes to the intermittent preventive therapy. The only potential problem is folic acid that is also given as part of the package, simply because you are trying to antagonize folic acid and you are also giving folic acid. But no problem. If you are on the type that has a very low dose or low strength, that is the 400 micrograms, then it will not interfere with your SP. But individuals who are on the high dose, that is the 5 milligram per tablet, there is a potential drug-drug interactions. And therefore, in these individuals who are on 5 milligram, on the day that you take the SP, is just one day. Make sure that you skip your 5 milligram folic acid, and then you continue from the next day. The 5 milligram will be there because the person will have risk factors when it comes to, for example, spinal bifida or anencephaly. These are called neural tube defects. So if you are pregnant and you are at an increased risk or high risk for neural tube defect like anencephaly or spinal bifida, it is folic acid at such high dose to ensure that this time you have adequate folic acid. You don't do the low dose. What if you don't get adequate absorption? So in such individuals, if you are giving birth to a child with spinal bifida or anencephaly, or you have a relative that has given birth to such an individual, then is in your family line, and therefore you are giving the high dose folic acid. This will interfere with SP, your strategy to prevent malaria. And therefore, on that day that you take SP, it's just once a day. Skip your 5 milligram folic acid and then continue. If you are on the 0.4 milligrams or 400 micrograms, the dose is too low to cause any harm. And therefore, that one you can continue in addition to the SP. Any queries? Any queries? SP is recommended to be taken either on an empty stomach or with food. Absorption will be adequate. As I said, preferably you have to take it on a daily observed therapy. You take it in front of the midwife because it will be part of the antenatal care. Any queries? Class captain.
Please, no queries.
All right. But always remember that it is not everybody who can also take our SP. Remember, SP contains sulfadoxine parametamine. Anybody who reacts to any of these two agents can take it. Sulfadoxine contains sulfur, which could be a problem in G6PD individuals. And therefore, those individuals may not take SP. First trimester, as we said, organogenesis is going on. So you have to wait until quickening, which is your 16th week gestational period. If you have severe malaria, then there is no sense in preventing malaria. You already have it. So go and treat. If you have any blood dyscrasias, these sulfadoxine, sulfonamides can even worsen it. And therefore, you may not be taking these agents. So if you have any of these contraindications, then your only strategy is to do prevention of bites. If you can't take the SP in pregnancy, then do prevention of bite. If you are pregnant and, for example, you are like an HIV patient who is on cotramazole can do same job as SP. And in that case too, you don't have to take SP because you are on cotramazole to prevent opportunistic infections. Any queries? Any queries? Okay. So another vulnerable group, children who are below 5 years. We mentioned pregnant women, children below 5 years, and non-immune travelers as the three who are classified as vulnerable when it comes to malaria. When they get it, it can easily graduate to severe malaria. So we have now solved the issue with pregnant women, prevention of bites, and using agents like SP to prevent the malaria. For pediatrics who are below 5 years, prevention of bite is also applicable. In fact, prevention of bite is applicable to everybody. Once you are in areas like Ghana, where we have a lot of issues with Anopheles mosquitoes that can cause malaria. But in addition, those who are vulnerable may do drugs to prevent the establishment because the prevention of bites can fail. So SP for pregnant women, but in children from 3 months to 59 months, which is just before you turn 5 years, we also have a combination of amodiaquine and SP. So this is their combination. They take sulfadoxine parametamine in addition to SP. The strategy is to give full treatment doses as if they are sick and we are treating.
Hello?
Yeah, hello?
Please, could you come again?
So in children between 3 months to just before 5 years, we do a combination of SP and amodiaquine because they are part of the vulnerable groups. So they will observe prevention of bite strategies, but in addition, they will also have to take SP with amodiaquine. Not all through, like all the time, but in the seasons where you have high level of malaria incidents or prevalence. For example, during the raining season where you have a lot of issues with malaria. So normally it's a 4-month stretch. So within that 4 months, you give full treatment doses as if they are sick, but they are not sick. We just want to achieve adequate therapeutic concentration so that even when they get the bite, the parasite will go and meet high levels of SP and amodiaquine in their plasma. And therefore, the sporozoites Please mute your mic. Mute your mic. And therefore, the sporozoites will be destroyed way before they establish a case of malaria. So remember the combination for seasonal malaria chemoprophylaxis, which is for children between 3 months and 59 months. That is just before 5 years. A combination of amodiaquine, full treatment dose, 10 milligram per kilogram body weight, plus sulfadoxine parametamine, which those who are below 2 years, they are going to take half a tablet. Remember, one tablet contains 500 milligrams sulfadoxine, 25 milligram parametamine. And those between 2 to 25 years will be taking one tablet. 5 years and more, you are not part of this strategy. That is why the first two are in green text. They qualified to take the seasonal malaria chemo prophylaxis. So it is below 2 years to 3 months and from 2 years to 5 years that we are talking about. So they take these SP doses plus 10 milligram per kilogram body weight of amodiaquine. Every month, they will take full treatment courses. So SP once every month, amodiaquine 10 milligram per kilogram body weight daily or in 2 divided doses for 3 consecutive days. For the 4 months, every month they do it. So that time, that 4-month stretch that we have a lot of issues with mosquito bites, a lot of mosquitoes breeding everywhere. They also arm themselves with these agents so that the moment the sporozoites are introduced, or even when they get into the liver and come back into the blood as merozoites quickly, before the clinical signs and symptoms occur, they will get the distraction from SP plus amodiaquine. Any queries? So that is for children 3 months to just before 5 years. Seasonal malaria chemoprophylaxis. Do not forget the combination. Amodiaquine plus SP. Full treatment doses. It's not prophylactic doses. How about those individuals who are boggers? They stay in areas where we don't have malaria. It could be an adult, a pregnant person, or even a child. What do we have for them, especially when they are coming back to Ghana? The interesting thing is that the normal adult who lives in malarious areas, the moment you leave that area to where you don't have malaria for 6 months, your so-called partial immunity is lost. Just 6 months, if you bugger for just 6 months, you come back holding your Vortic water and your small bag moving around, bugger, you've lost your immunity. If you stay there below 6 months, you still have your immunity intact. So when you come, there's no need for you to be considering chemoprophylaxis. But 6 months and above, you've lost your immunity. So you should behave like a typical bugger. The whites, the blacks who are there when they are coming to Ghana, then they always go to their GP for some of these medications to help protect them from getting the condition when they come to Ghana. What are the options available and what are the issues with each of them? Remember, it's not only normal adults who stays in areas where we don't have malaria. You could have pregnant women. Do we have anything for them? Because the intermittent preventive therapy is for pregnant women living in Ghana. Seasonal malaria chemoprophylaxis is for pedics between 3 months to 59 months living in Ghana. How about pregnant women living outside where there is no malaria? Children in that group living outside where there is no malaria, and normal adults living in those areas.